Hi, my name is Dr. Katie Traylor, and I'm from UPMC in Pittsburgh. Welcome to Session 3, From Symptom to Diagnosis, What's Wrong? Our first speaker, Dr. Tamimi, will be discussing sleep-disordered breathing, what a radiologist needs to know.
Hello, everyone. My name is Dania Tamimi. I'm an oral and maxillofacial radiologist, which means that I'm a dentist trained to read radiographic imaging for dentists for the purposes of dental treatment. One of the hot topics right now in our field is the radiographic assessment for sleep-disordered breathing. And many of our analyses are in the area of the craniofacial complex. So I thought that it would be interesting for me to share this with you. So what is sleep-disordered breathing? It's an abnormal respiratory pattern during sleep. Many people die of this each year, and the most prominent of whom was Princess Leia. Carrie Fisher passed away, and the cause of death was sleep apnea. And if left untreated, then it can increase the risk of many health problems, including this list right here. So this should be very relevant to us as healthcare providers to understand how we can help diagnose these risk factors in our imaging. Obstructive sleep apnea is recurrent collapse of airway during sleep, and there are different degrees to OSA and different presentations for sleep-disordered breathing. We've got snoring, we've got upper airway resistance syndrome, and we've got obstructive sleep apnea syndrome. Now, in order to understand our role in this field of sleep-disordered breathing, we need to do a little experiment. And let's just imagine that we have three sets of straws: a smoothie straw, a regular straw, and maybe a coffee stirrer, the ones that look like straws. And if we were to bring each of these to our lips and try to draw the breath in through each of these straws, we'll notice that it's easier for us to draw the breath in through the smoothie straw versus the normal bore straw versus the coffee stirrer, and that's because of Poiseuille's law. Poiseuille's law is a law in physics that we usually use to measure flow through catheters, and it's applicable to airflow as well. So a flow increases with the increase in the diameter of a tube, and of course decreases when that tube becomes smaller. So what we're looking for in our radiographic imaging is all the factors that can lead to increasing the resistance, to creating a smaller straw. So we're looking for things that change the anatomy, increase resistance, cause turbulence or laminar airflow, and then also increase collapsibility of that tube while that person falls asleep. So when we evaluate our airway, it's not just the air-filled spaces, but it's also the soft tissue components that surround these air-filled spaces and the hard tissues that support them. And this is where we as radiologists can shine, because we can analyze these very easily on our imaging. So these are the things that I look for. They are nasal obstruction. Remember, I'm going to be starting from the tip of the nose all the way down to the hyoid. Okay, so everything on my scan of the head and neck, from the tip of the nose down to the hyoid, and I'm working sequentially down the tube. So we're starting with the nasal cavity, looking for nasal obstruction, looking for any sinus pathology, nasopharyngeal pathology, or pharyngeal morphologic predisposing factors and pathology, maxillary and mandibular morphologic predisposing factors. The TMJs, and you may be wondering why, but I'll show you in just a minute. And then hyoid bone position. And I also evaluate the head position, because depending on where we position our head, we can end up with a larger or smaller airway. And I'll explain this as we go along. So let's first start with the nasal obstructions and the sinus pathology. So in the nasal cavity and the sinuses, we're looking for patency of the external and the internal nasal valves, transverse dimension of the nasal cavity, morphology of the nasal septum, morphology and symmetry of the turbinates, patency of sinus drainage pathways, and the presence of sinonasal pathology. So starting with the nasal valves, we have two sets of nasal valves. We have the external nasal valve and we have the internal nasal valve. Now, the external nasal valve is easy to evaluate clinically, but the internal nasal valve, we can look at clinically as well with a rhinoscope, but we can also look at radiographically. And we do that by creating this cross-section right here to visualize this area, which is the internal nasal valve. And this area should be patent and more than 15 degrees There are some things that can cause nasal obstruction at this level. Some aesthetic procedures, as well as trauma, can narrow that nasal valve and create the sensation of obstruction, inability to draw air in and out through the nose. And of course, many of our imaging will cut off the tip of the nose. So if we do have that piece of anatomy on the scan, we comment on it. If not, then we just leave it alone. So let's travel into the nasal cavity, going through the piriform aperture into the nasal cavity. And I like to create 3D imaging of the skull to look at the morphology of the face, the mid-face, the nasal cavity, as well as the maxilla. And I look at the transverse dimension of the nasal cavity, and I also look at the transverse dimension of the maxilla, because the two are linked to one another. See, the maxilla makes up not only the arch, but also part of the nasal cavity. So if there is narrowing of the maxillary arch, sometimes we also have narrowing of the nasal cavity. And this is one of the things that narrows the straw at this level. Now, I'll talk about why this happens when we get into the TMJ section. Part of that also changes the morphology of the nasal septum. We have some morphologies that we can visualize, and many of us do visualize on our imaging. There's the S-shaped deviations, there are the C-shaped deviations, there's anterior dislocation, and of course the nasal septal spurs. And these can be either in the bony components of the septum or in the cartilaginous components of the septum. And all of these will change the dynamics of the flow of the breath into the nose, and may even cause an obstruction on one side of the nose. And it's important for us to look through the imaging of the nasal septum at every level to identify these spurs and the location in which they occur. Some other things that will change the flow of the air into the nasal cavity are the presence of concha bullosa. Okay, so we can have concha bullosas in any of these concha. The middle turbinates are the most common ones. As we know, we can have bilateral concha bullosa, we can have unilateral concha bullosa, which are usually associated with a deviation of the septum to the opposite side. And that all changes the dynamics of the flow of the air into the nasal cavity. Paradoxical nasal turbinates, those also change the flow of the air into the nasal cavity, increasing the resistance of the air as it flows into the nasal cavity. We also need to be looking at our drainage pathways to make sure that there's no sinonasal pathology, inflammatory sinonasal pathology. So we look, of course, and I don't need to teach you guys how to do this, the frontal recess, the sphenoethmoidal recesses, and of course we look for pathology within the sinuses as well, and of course the ostomeatal unit, the infundibulum, and the patency of all these. So this is part of this sleep disordered breathing analysis. Other things, of course, we're looking for obstruction. So things like foreign bodies that have been shoved into the nasal cavity, or the things that we're very familiar with in our field, pathology, sinonasal pathology, that can give the sensation of obstruction because obviously it's obstructed, right? So now we're leaving the nasal cavity, and at the very end of the nasal cavity, we're looking at the posterior nasal spine and the choana. And I always look at this area right here because polyps like to happen in this area. So I usually see little polyps spilling backwards into the nasopharynx from the inferior turbinate or from the area of the inferior turbinate, and I look for those. Moving into the nasopharynx. In the nasopharynx, we need to be looking at the soft tissues there, of course, the size and morphology of the adenoids and the effect of those adenoids on the airway lumen. I always look at the morphology of the fossa of Rosenmüller and Torres tiberius and the whole area, looking for symmetry to make sure that this adenoid tissue isn't something else. And in my world, I deal with cone beam CT, so I don't get to see actually I see the soft tissue, but I don't get to characterize the soft tissue. Of course, you have the advantage of being able to characterize whatever soft tissue is in this area. So the progression of adenoid development, they're not visible at birth. They reach peak size at 5 years of age. They continue until age 12, and then they diminish sharply at age 16. In a young individual who's still childhood and early adolescence, a large amount of adenoid tissue narrowing the nasopharynx can compromise that person's ability to breathe in and out through their noses, thus leading to what we know as adenoid facies, okay, where people start to open up their mouth to breathe, and then the face develops in an elongated fashion. When I look at these adenoids, I always look at the clivus. I always look at the support around the soft tissue, because once in a while you see something nasty like a nasopharyngeal carcinoma that can erode into the sphenoid and, of course, into the clivus as well. Now let's move into the oropharynx. So in the oropharynx, we have morphology and pathology that we need to be aware of. And some of the anatomic structures whose morphology we need to evaluate are the soft palate and the uvula, so its length and thickness. We need to look at the size and symmetry of the palatine tonsils, the tongue position in the oral cavity, and the lingual tonsil morphology. And all these soft tissues will affect the size of the oropharyngeal airway. And that, coupled with the position of the cervical spine, will also change the dimensions of the oropharynx. So just to bring things into perspective, dentists are really hung up on numbers. We really like to measure things. And one of the things that they like you to include in your reports about patients who do have sleep disordered breathing is how big is the airway. On cone beam CT, we have a volumetric measurement that we do. I'll show you that in just a second. And I take that from the base of the epiglottis all the way to the level of the hard palate. But if you don't have a volumetric measurement, you can just do an area measurement here in the area that you believe is the smallest area dimension. This oropharynx is a collapsible tube. The numbers that you get on the cone beam CT may not represent what the patient is experiencing when they actually do have a sleep apneic episode. But knowing how large this airway is will give you an idea of what the risk is for sleep disordered breathing. And usually if you have a really tiny airway, about 50 millimeters square, that indicates a higher risk of sleep disordered breathing. Whereas you have a moderate risk between 50 and 120. As it gets larger, then the risk decreases. But that doesn't mean that you can't have an apneic episode if you have a large airway. These are the volumetric measurements that I create on my cone beam CT, and I create it from the fixed margin of the epiglottis all the way to the level of the hard palate. And this person does have a relatively large airway, but because of her facial morphology, because of the osseous structures here, she actually doesn't have much space in her oral cavity. When she falls asleep, her tongue falls back into her oropharynx, and this is actually a confirmed case of mild sleep apnea. So I wouldn't hang my hat on the numbers, but I'm just telling you that dentists do want to see the numbers. So one of the pitfalls of this imaging is that the patient is awake. When does a sleep apnea episode occur? It happens when the patient is sleeping. And on cone beam CT, most of these patients are upright too, so that you have gravity helping this person as well as muscle tone. Now, I know some institutions, more of a academic exercise, will put the patient in the MRI and create dynamic MRI imaging to see what happens to that airway when the person falls asleep in the MRI machine. Now, one thing that we do know is that obesity increases the risk of sleep disordered breathing. It increases the risk of obstructive sleep apnea, and that does so by decreasing the dimensions of the oropharynx. So when you are obese, you are depositing fat in the parapharyngeal structures as well as in the tongue and in the soft palate, and all that becomes very flaccid, large and flaccid. So people who are obese tend to have smaller airways compared to controls. Okay, so some of the boundaries of the oropharynx are the soft tissues, as I mentioned. We've got the soft palate, we've got the tongue, we've got the epiglottis, and we also have the hard tissues that surround these. And all these are going to affect this tube. Now, clinically, some clinicians will do the Mastoiditis score for the tongue, the size of the tongue, and also how much of the oropharynx is visible clinically. And of course, we know that this was developed by anesthesiologists to predict the ease of intubation. But we dentists, when we're doing our sleep disordered breathing analysis, we are looking at this Mastoiditis score. So the size of the tongue, and this is hard to do radiographically, but I'm just giving you an idea of what is done there. Something that you can do is measure how long the soft palate and the uvula are together, as well as how thick that structure is. And the thicker it is and the longer it is, the more flaccid it is, the higher the risk for sleep disordered breathing is. Palatine tonsils can also be graded. They can be graded clinically and they can be graded radiographically. And the larger the tonsils are, the smaller the straw is, the smaller the tube is, the harder it is for someone to bring breath into their bodies. Now, we know that children tend to have larger tonsils. Okay, adults may have large tonsils as well, but children tend to have larger tonsils and those diminish with size as well, just like the adenoids. In my world, cone beam CT, this is what I see, and I comment on, the size of the tonsils. And of course, in your world, you have the ability to see there's things like peritonsillar abscesses and other nasty things growing inside the palatine tonsils that may affect the size of the tonsils bilaterally or unilaterally. So now let's descend into the lingual tonsils. And in the lingual tonsils, this area can also narrow the oropharynx. And we can have large lingual tonsils because inflammatory regions. And some of that inflammation can be due to gastroesophageal reflux. So with the reflux of the acid into the oral cavity, this area gets irritated, it enlarges. And we also know that we do get squamous cell carcinomas that can occur in this area. That enlargement of the soft tissues here can displace the epiglottis and fill the vallecula. On cone beam CT, I can't tell you what this is, but I can tell you that there's a soft tissue mass here and it's narrowing the airway. You guys can probably give them a little bit more information about what that soft tissue mass is. Now let's move into the hard tissues, so the maxilla and the mandible and the TMJs and the hyoid bone. So let's start by why we need to know about these hard tissues. So these hard tissues is what encases the soft tissues that surround the airway, okay? And the support of those hard tissues, if that area is not large enough to encase the soft tissues, then we have a situation where those soft tissues need to go somewhere and they're going to go into the oropharynx. So let's start with the maxilla and the mandible. Some of the predisposing factors are them being too small. Their shape, the really narrow arches. So when you look at them on a cone beam CT or a CT or MRI, it kind of looks like a V rather than a wide arch, a wide U. Also in the coronal plane, you'll see that the actual palate looks more like an angle rather than a big shelf. Wide shelf. You want to look at the transverse dimension of the maxilla and the mandible, the growth pattern, what's happening in the growth of the maxilla and the mandible. And some of it is due to TMJ issues, and I will talk about that in just a second. Teeth, agenesis or early extraction, that can cause disuse of atrophy of the alveolar processes, decreasing the amount of space available for the tongue and the oral cavity, and the presence of tori that just crowd everything out. So the tongue lives in a box, and the box needs to fit the tongue. So the tongue can't be too big and the box can't be too small. Some of the things that can crowd the tongue out of the oral cavity are the tori. So these are really large palatine tori. We can also have mandibular tori here. And sometimes we'll have alveolar process exostoses that make that area even smaller. There are some phenotypes that we can see are very closely associated with the box being small. I talked about maxillary hypoplasia, but look at all these patients right here. They all have small mandibles. And if we were to look inside their mouths, we'll see things like anterior open bites. The transverse dimension of their arches is small. Their condyles are small, and also their airways are small. So look at that. All these airways are small. So what's happening in these patients? Their condyles are small. That's reducing the size of the condyles. That's going to change the position of the mandible. The mandible is going to rotate backwards and displace all the soft tissues backwards into the oropharynx. So let's go into the TMJs and their role in the development of the craniofacial complex, particularly in the oral cavity, in the maxilla and the mandible. I want you to take a look at this condyle. And you may say it's a small condyle, it's a hypoplastic condyle, but I want you to look at a very important diagnostic point. And that point is the posterior height of contour of this condyle is at the same level as the anterior height of contour. If you see this appearance in an adult, okay, and you see that there isn't much condyle on top of these heights of contour, it's flattened and the joint space is narrowed, then you know that this condyle has undergone degenerative joint disease earlier in life. And this is called idiopathic condylar resorption. Now, this condyle is a growth site. And if this condyle is compromised before the growth and development of the mandible is completed, then there are going to be changes to the rest of the mandible. Here is adult mandible and adult skull, and the teeth are in maximum intercuspation, and the condyle is seated in the fossa. And we call this situation orthopedic stability, where the joints are all in the right place. But when we have an issue where the condyles are reduced bilaterally, then now we have orthopedic instability, and this condyle is going to want to sit upwards. It's going to go upwards into the fossa, and when it does so, it's going to take the mandible along with it. And it's going to rock all around a molar fulcrum, whatever the last molar tooth is, and that bite is going to open up anteriorly. So that's what happened with those three individuals. The bite opened up anteriorly, but that's not all. Now, with that posterior rotation of the mandible, we have a displacement of those soft tissues into the oropharynx. And because those soft tissues are also attached to the hyoid bone is going to descend as well. So the position of the hyoid is highly dependent upon where the mandible is. All right. And so one of the things, the risk factors, or one of the things that we look for radiographically rather, is where is the hyoid in relation to the mandible? And if I were to draw a line at the level of the mandibular planes and then take another line perpendicular to that and measure it from the body of the hyoid to that line, it should not exceed these numbers. So 14 millimeters below the mandibular plane is the average. Females are a little smaller than males. And you can do this on a 2D Ceph, or you can do this on a 3D, on a coronal, cone beam CT, MRI, or CT. As I mentioned, these people can't breathe properly because all that stuff has been crowded back into their oral pharynx. So one of the protective mechanisms for individuals with this phenotype is to move their head forward. And when they move their head forward, they increase airway dimensions. Try it now. Sit up straight, take a deep breath in through your nose. Just notice how your breath flows, and then move your head forward, breathe in and out. Notice how much more space you have. Then move your head back and breathe in and out, and notice how much less space you have. So when you have patients with this phenotype, with this head forward position, then think to yourself, could that be because they have issues with sleep disordered breathing? Could they have a really small oropharynx? Now, the story continues. With that posterior rotation of the mandible, there are some morphologic changes that can occur to the maxilla and the mandible, and that's because of the muscles that surround the alveolar processes, the muscles of facial expression on the outside, and then the tongue on the inside. And in dentistry, we know that the teeth erupt into the neutral zone, a space in between those muscles, those groups of muscles, where the net forces are zero between here and here. So if we lose the tongue because it was displaced backwards, then what's going to end up happening is the orbicularis oris muscle and some of the other muscles of facial expression are going to push the alveolar process and the teeth backwards, decreasing the anterior-posterior dimension of the maxilla. All right, and just showing you the proximity of the orbicularis oris to the arch, to the alveolar processes. Buccinator does the same thing in the back. So buccinator also hugs the alveolar processes. If we lose the tongue, then the buccinator muscles will continue to push, and that's going to decrease the transverse dimension of the arches, especially in the maxilla. And if you decrease the space in the oral cavity, then the tongue has nowhere to go but back into the oropharynx. These are some of the risk factors that we look for, both clinically and radiographically. In my practice is radiographic, so I look for them radiographically. This is what it looks like clinically in an individual who has this type of phenotype. Look at this really narrow palate. Look at this V-shaped arch. Look at the crowding of the teeth because there's no space. And also because they've grown, or she's grown into this pattern, her nasal cavity is also narrow because she's got these pinched nares and a very long face because of the posterior rotation of the mandible. And the etiology of all that was bilateral degenerative joint disease that occurred earlier in life, idiopathic condylar resorption. So the last thing I'm going to talk about is this evaluation for head posture. And I just want to say, I'm not going to put any slides up here, but when your patient is on the gantry, and if they have this forward head posture, then if they don't have anything to support their head while they're lying supine, then their head is going to crane backwards, and that's going to change the dimensions of the oropharynx. So these numbers might not mean anything. If you do want to capture the oropharynx in natural head posture, then please make sure to place enough padding underneath the patient's head to simulate their natural head posture. Because otherwise, whatever dimensions that you have on your imaging will not be accurate. It's the same thing with cone beam CT, where the head is postured forward or backwards in order to use head stabilizing devices that we have in association with this machine. So that's it. That's a quick whirlwind tour into the world of sleep disordered breathing and how we as radiologists can help our referring clinicians identify the radiographic risk factors. Thank you so much for your attention. This is my email. I was really looking forward to seeing you here in Orlando. What can we do? Next year, everybody. Thank you very much.
Our second speaker, Dr. Pramanik, will be discussing TMJ disorders, workup, and imaging findings.
Hi, I'm Dr. Pramanik from Lenox Hill Hospital and Northwell Health. I'll be talking on TMJ disorders, workup, and imaging findings. Learning objectives for my talk. The temporomandibular joint is a synovial joint between the condyle and glenoid fossa. It's a diarthrodial joint. It has rotational and translational movement. The disc or meniscus is biconcave in shape. It's composed of an anterior and posterior band connected by the intermediate zone. The disc divides the joint into two compartments. Temporomandibular disorders include myofascial pain and TMJ dysfunction. Internal derangement is defined as the abnormal disc position in relation to the condyle. Etiologies for internal derangement include trauma, bruxism, malocclusion, and stress. It may affect up to 28% of the population. Many cases resolve spontaneously. Signs and symptoms include pain and clicking of the joint and limitation of movement. With a displaced TMJ disc, we get clicking as the disc recaptures and comes into a normal position. With posterior attachment stretching, there is no more recapture. There is loss of the click and range of motion. With perforation of the posterior attachment, there's constant displacement with improved range of motion. Majority of TMJ disorders can be treated effectively by non-invasive and non-surgical interventions. Initial therapy includes NSAIDs and/or muscle relaxants, occlusal splints, and physical therapy. Refractory cases may go to intra-articular injections, trigger point muscle injections, or Botox injections. Surgery includes arthrocentesis, arthroscopy, disc repositioning, and replacement. How do we image the TMJ? Imaging modalities include X-rays, tomography, CT, and MRI. Nowadays, there's limited interest in utilizing X-rays and tomography. There's little or no role in assessment for internal derangement. CT is most useful for evaluating osseous changes, especially looking at erosions, sclerosis, and osteophytes. Here we can see narrowed right temporomandibular joint. We can see flattening of the condylar head as well as the articular eminence. There's beaking of the condylar head with subchondral cyst formation. Here's a ossified and anteriorly displaced disc. MRI is really the gold standard for evaluating the temporomandibular joint and has replaced other imaging modalities. Indications for MR imaging include failure of conservative therapy, progression of symptoms, and preoperative assessment. MRI really evaluates the disc in terms of its location and morphology, as well as the surrounding soft tissues. MRI findings most associated with pain include bone marrow edema and disc displacement without reduction or recapture. Displacement can be seen in up to 30% of asymptomatic volunteers. Normal disc position can be seen in 16 to 23% of symptomatic patients. Minor amounts of fluid can be seen in normals. Our TMJ imaging protocol: in the open mouth position, we acquire 3-pane localizer, then axial T2 weighted images, and then sagittal proton density images. In the closed mouth position, we again get a 3-pane localizer, followed by sagittal proton density, coronal T1, and sagittal stir imaging. Finally, we acquire dynamic images utilizing HASTE imaging. Some protocol tips: use 3 millimeter lower section thickness, 0 to 1 millimeter image gap, small field of view, typically 14 to 18 centimeters. Always scan both joints. We do not use a bite block, and we give our patients a 60 cc syringe to bite. IV contrast is not indicated in routine cases. We give gadolinium when we're concerned of inflamed synovial or inflammatory arthropathy. We do not use a TMJ coil. We use our head coil. Acquiring the right image, this is really important. We acquire our sagittal oblique images parallel to the coronoid process and condylar head. Our coronal images are acquired perpendicular in orientation. This is what we'll get in a nice study. Here you can see the sagittal images in the closed mouth position. Here we have our open mouth positions, easy to see as the mouth is open, our stir images, and our coronal T1 weighted image. How about functional information for disc pathology? This is where dynamic imaging is really important and really gives us a true sense of range of motion. I've been utilizing HASTE imaging for over 15 years. I like HASTE imaging because it's quick, 30 seconds or less. A side benefit is reduced susceptibility artifact, which can improve diagnostic yield in the setting of dental hardware. Here's an example from one of our cases where you can really see the condylar head as it moves forward with translation beyond the articular eminence. This hypointense structure is the meniscus or disc, which is going in between the articular eminence and condylar head. This is a really translation. Besides HASTE imaging, you can use FIST imaging, fast imaging with steady state precision. Advantages here include magneticization state with increased signal to noise, as well as ultra short TRs with high spatial resolution. Let's look at normal MRI anatomy on our sagittal oblique images. It's important to identify 7 structures. If we start out laterally, here's our external auditory canal, our condyle, our articular eminence, our articular disc or meniscus, our retrodiscal soft tissues or bilaminar zone, our lateral pterygoid muscle, and finally our temporalis muscle. Here in the open and closed mouth position, we see a normal meniscus or disc, which is this iso-intense structure, again, biconcave or bow tie shape. The posterior band of the meniscus should be perpendicular to the condylar head at a 12 o'clock position when we look at the face of a clock. MRI imaging signs of TMJ dysfunction, this is referred to as direct signs, include disc deformity, whether there's a crumple, rounded, flat, or perforated appearance to the disc. It's important to describe this. Evaluate for abnormal disc displacement. This can be anterior displacement, posterior displacement, lateral or medial displacement. You can also get an anterior displacement with a medial component to it. Pure lateral or medial displacement are about 5 to 10% of disc displacement. Most are anterior displacement with a medial or lateral component in about 17 to 20%. Abnormal disc movement, anterior displacement with reduction or recapture, anterior displacement without reduction or recapture, or a stuck or fixed disc. Osteoarthritic changes include flattening, osteophytes, and sclerosis. MRI signs of TMJ dysfunction, which are more indirect, include joint effusion, increased thickness of lateral pterygoid muscle attachments, and rupture of retrodiscal layers. I also include marrow abnormalities. Let's talk about disc deformity. Here you can see this is what the normal disc should look like, a larger posterior band when compared to the anterior band connected by the intermediate zone. Here we can see an enlarged posterior band. Here we have a flattened disc. Here we have a folded disc, and finally a somewhat oval or rounded disc. Here is a folded disc. You can see it again folded onto itself, especially along the anterior component. Here we have a rounded disc. Here we can see central perforation. There's displacement of the anterior and posterior bands. Disc displacement. This is an example from a 31-year-old female with classic types of TMJ history. She's suffering from clenching, grinding, locking, popping, and as well as pain. Here on the closed mouth position, we can see some irregularity of the condylar head. If we look at the posterior band of the posterior margin of the posterior portion of the meniscus, when we look at where the condylar head is, this is probably at about the 10 o'clock position in terms of the face of the clock. Otherwise, it has a normal morphology. In the open mouth position, we can see that the disc moves forward, normal translation. The disc is in between the articular eminence and the condylar head. This is displacement with reduction or recapture. Same patient, we can see that there is a small joint effusion as well as some increased signal within the condylar head, suggestive of edema. Here are the dynamic images where you can see the translation and recapture of the meniscus. Another patient with left jaw pain. We can see our technologist put in other details. This is for pre-surgical planning. We can see a flattened and irregular condylar head. The disc is anteriorly displaced, not in the normal position along the 12 o'clock position relative to the condylar head. Again, with the opening of the mouth, you can see that the disc is anteriorly displaced. So this is anterior displacement without reduction or recapture. We can see that there's increased signal within the retrodiscal soft tissues in this patient, as well as edema within the condylar head. With lateral displacement, one of the ways we can describe this is really looking at the external auditory canal. Here's the articular eminence. We can see the condylar head, and here's our deformed disc. This is much easier to see on our coronal image, where you can see the lateral displacement of this disc. Progression of degeneration. Here is the disc, which is anteriorly dislocated. We can see in the open mouth position there is normal translation. The disc reduces or recaptures in a normal position between the articular eminence and the condylar head. We can see a large joint effusion on the STIR images. Same patient, sometime later, where there remains anterior dislocation of the meniscus. However, now there is no longer reduction or recapture, and you can see that there is a decrease in the amount of the joint effusion. A stuck disc, the disc remains in a fixed position relative to the glenoid fossa and the articular eminence in the open and closed mouth position. This is thought to be secondary to adhesion. It limits translation, may be associated with pain. In this example, we can see that the disc is anteriorly dislocated along the articular eminence. If you look at the open mouth views, you can see that the disc is at the same position. There really is a very minimum translation. And when we look at our dynamic images, again, very little motion in terms of translation, and you can see that the disc is really relatively fixed in position. So this is what a stuck disc looks like. Another patient, our clinician has given us some helpful information. Limited mouth opening. Here on the closed mouth view, we can see that the disc is anteriorly dislocated. With the open mouth views, we can see that there is slight translation. The condylar head has moved forward, but the disc is very similar position. On our dynamic images, again, poor translation. The disc remains fixed in position. So this is a stuck disc. Follow up on this patient about 9 months later. You can see that here we have our anteriorly displaced disc, but now there's reduction or recapture. Joint effusion, usually defined as a large amount of fluid, unusual sign in asymptomatic individuals. Only small amounts may be seen. Has been associated with TMJ pain and disc displacement and represents an early change that can precede osteoarthritis. This is best seen on the STIR images. This is a humongous joint effusion, which you can see in the inferior and superior portions of the joint space. And on the dynamic images, you can see how the joint fluid limits translation. This almost gives us a myelographic effect. Another patient initially with very little or if any fluid within the joint space, and then over 9 months, we can see this joint effusion that has developed. Increased thickness of the lateral pterygoid muscle attachments. The increase in the lateral pterygoid muscles believed secondary to hyperactive etiology from internal derangement. This results in a thickened lateral pterygoid muscle attachment. It's important to recognize this and not be fooled in calling this the meniscus or disc. Here's our thinned meniscus, and this is the lateral pterygoid muscle attachment, which is thickened. Marrow abnormalities here on our STIR image, we can see that there's hyperintense signal within the condylar head, suggestive of edema. Another example on the T1 weighted images, you can see areas of hypointensity, mixed signal on the STIR images with areas of sclerosis and edema. The retrodiscal soft tissues are composed of retrodiscal layers and vasculonervous tissues. These play an important role in normal disc movement. Increased signal is seen in the retrodiscal soft tissues of painful joints. We can also see decreased signal in chronically displaced disc. Here we can see the increased signal within the retrodiscal soft tissues. Osteoarthritis. They include flattening and irregularity, osteophyte erosions, and sclerosis of the condyle, typically seen in long-standing joints with disc displacement and TMJ dysfunction. Osteoarthritis may be present in older patients and may be asymptomatic. Here we can see a condylar head flattening, beaking, irregularity. This is another example where you can see the diffuse sclerosis with hypointense signal within the condylar head. This is obviously very easier to see with CT. Again, sclerosis, irregularity, flattening, erosive changes within the left condylar head. Again, better demonstrated in these blown up images of the erosive changes within the left condylar head. It's important to have some type of history when looking at TMJs. This is a questionnaire that I used to send out to patients, and you can see how this can be helpful and then kind of localize where their symptoms are. This is how I organize all my images on the PAC station. So I put my sagittal obliques together, my coronal T1 weighted images, my dynamic images, and I use my T2 weighted images as really localizing each side that I'm in. So in summary, the most important anatomic structure of the TMJ is the meniscus or disc in the closed mouth position. Remember, the posterior band of the disc or meniscus should be immediately above the condyle at roughly the 12 o'clock position in the face of a clock. MRI signs of TMJ dysfunction include abnormal disc morphology and displacement, osteoarthritic changes of the condyle, and joint effusion. Thank you very much for your attention.
Our third speaker, Dr. Hagiwara, will be discussing Otalgia, spectrum of causes and imaging findings.
I'd like to thank Alona and the ASHNR for the invitation to speak. I have no disclosures. Otalgia is ear pain, and causes of otalgia can be divided into primary otalgia, which is pain caused by ear disease, and secondary or referred otalgia, which is pain from a distant non-otologic source, or pain from structures distant from the ear. Primary otalgia is more commonly seen in children, whereas referred otalgia is more commonly seen in adults. So starting with primary otalgia. So listed here are some causes of primary otalgia, and by far the most common cause of primary otalgia are ear infections, including otitis externa, otitis media, and mastoiditis. And typically these patients with ear infections will also present with fever, ear drainage, and periauricular swelling. So here we have an 11-year-old patient who presented with left ear pain and erythema after swimming. And you can see thickening of the walls of the left cartilaginous external auditory canal compared with the normal right side. You can also see surrounding inflammatory changes in the periauricular region with fat stranding. There's no associated abscess, and there's no associated bony erosion. And so these are typical findings of otitis externa, also known as swimmer's ear. And these patients typically don't have to be imaged, though they may be imaged with severe infections to look for associated complications. These patients typically present with ear pain, tenderness, and swelling, and decreased hearing, and they can be treated with topical antibiotic therapy. Here we have a 76-year-old with right ear pain and drainage, and similar to the last case, you can see thickening of the walls of the right external auditory canal. But in this case, we can also see frank bony destruction of the walls of the canal, the surrounding temporal bone, and the adjacent skull base. We can also see abnormal soft tissue in the deep spaces of the neck below the skull base in the prevertebral, parapharyngeal, and carotid spaces at the level of the nasopharynx. And so these findings are consistent with necrotizing otitis externa. This is classically known as malignant otitis externa, but this name has fallen out of favor as it's really a misnomer. It's not a malignant neoplastic process, but just rather a very aggressive infection with associated osteomyelitis of the temporal bone. It's most commonly seen in elderly diabetics, but can also be seen in immunocompromised patients, including patients with AIDS. Pseudomonas is the most frequent and involved pathogen, and patients will also often present with purulent otorrhea, and they may also develop lower cranial neuropathies depending on the foramina involved at the skull base. On imaging, as you saw in our case, you'll see bony erosion of the temporal bone and skull base and inflammatory soft tissue extending into the deep spaces of the neck. It's thought that these infections spread inferiorly through the fissures of Santorini, which are small gaps between the cartilaginous rests of the external auditory canal. Now, a superinfected neoplasm is in the differential both clinically and on imaging, and so these patients should be closely followed to evaluate for an underlying neoplasm after the infection has been treated. And these patients are treated with IV antibiotics and possibly surgery. Acute otitis media is infection of the middle ear cavity and most commonly is seen in children. Patients typically present with otalgia, muffled hearing and fever, and the pain may be severe, but the ear itself is not tender, unlike with acute otitis externa. A otoscopic exam demonstrates a middle ear effusion and erythema, bulging, or a cloudy appearance of the tympanic membrane. These patients typically do not require imaging, and most will resolve spontaneously, though many patients may also be treated with oral antibiotics. Mastoiditis generally develops from acute otitis media, and patients classically present with otalgia, fever, postauricular pain, as well as postauricular erythema and swelling as you see in this photo. They may also have otorrhea and hearing loss. These patients are treated with IV antibiotics, and this is really a clinical diagnosis, and the main point of imaging is to look for complications. And complications include coalescent mastoiditis with erosion of the mastoid septations and cortex, subperiosteal abscess, Bezold's abscess, which is an abscess below the mastoid tip, dural sinus thrombosis. Here you can see erosion of the sigmoid plate with adjacent thrombus in the proximal sigmoid sinus. Complications also include intracranial collections, and here we can see loculated collections along the falx and right convexity with central diffusion abnormality consistent with subdural empyema that was in this case due to mastoiditis. Now moving on to causes of chronic primary otalgia. And here you can have cholesteatoma of the external auditory canal, which can present as a dull chronic ear pain and pruritus. A pearly white mass with debris may be seen on otoscopic exam, and on imaging, you typically see a soft tissue mass in the canal with associated bony erosion and these very characteristic flecks of calcification. Neoplasm is in the differential clinically and radiographically, and so these lesions should be biopsied. Middle ear cholesteatoma can also be a cause of chronic primary otalgia, and here we have a 34-year-old male with chronic left-sided otalgia and hearing loss. And here we see lobulated soft tissue in the left middle ear cavity and erosion with absence of the long and lenticular processes of the incus compared with the normal right side. Carcinomas of the external auditory canal can also cause chronic otalgia. Squamous cell carcinoma is most commonly seen, followed by skin cancers including basal cell carcinoma and melanoma. CT best demonstrates bony erosion like you see here in this patient with basal cell carcinoma, and MR best demonstrates perineural tumor spread and intracranial extension. The first line of nodal drainage is to the parotid and level 2 nodes, and so you want to look carefully in those areas for metastases. And as I mentioned previously, carcinoma may be indistinguishable from necrotizing otitis externa and cholesteatoma. These cancers are typically treated with a combination of surgery and radiation. A foreign body within the ear canal can also cause ear pain, and this child had a tympanostomy tube that had self-extruded from the tympanic membrane, and it became embedded in the posterior ear canal with associated granulation tissue. Acute barotrauma can also cause extremely painful otalgia. It's associated with flying or scuba diving, and they'll often have a clear history that suggests this diagnosis. The sudden development of negative pressure in the middle ear cavity can cause acute retraction or rupture of the tympanic membrane, as well as rupture of the vessels, causing bleeding in the middle ear and tympanic membrane. But this is really a clinical diagnosis that does not require imaging. So those are some of the more common causes of acute and chronic primary otalgia. And so now moving on to referred otalgia, where the source of pain is distant from the ear. And this again is most commonly seen in adults, and these patients will have a normal ear exam. So the ear is unique in that it is a small structure supplied by many sensory nerves. There are 6 nerves total, including 4 cranial nerves and 2 cervical nerves. And all of these nerves converge onto the ear, and all of these nerves also receive sensory innervation from a number of other structures in the head and neck. And the theory is that the central nervous system gets confused about the location of the source of pain, and the pain from a distant source gets referred to the ear. And this is similar to or analogous to a patient experiencing left arm pain when having a heart attack. Many cases of referred otalgia are benign, though it may be an early sign of serious pathology, and neoplasm is the most worrisome cause of otalgia that we don't want to miss. Now, the intensity of the pain doesn't really correlate with the seriousness of the disease. Dental disease can produce very severe pain, while a cancer may produce a very mild, dull pain. As I mentioned, there are 4 cranial nerves and 2 cervical nerves that innervate the ear. The mandibular division of the trigeminal nerve, V3, is the most common sensory neural pathway leading to referred otalgia. The mandibular division innervates a large territory of the ear through the auriculotemporal nerve, and it also has multiple other branches, including the lingual, the buccal, and the inferior alveolar nerves that innervate the lower teeth, the mandible, including the TMJ, the parotid, submandibular, and sublingual glands, as well as the oral cavity. And so pathology of all of these structures can cause referred otalgia. And pathology includes dental disease, which is the most common cause of referred otalgia, and TMJ disorders, which is the second most common cause. And then you can have infections and tumors of the mandible, the salivary glands, and oral cavity. They can all cause otalgia. So here we have a 44-year-old male who reported a history of chronic right facial pain and otalgia. And on the synostoid, you can see periapical lucency surrounding the roots of the right maxillary molar tooth and dehiscence of the overlying right maxillary sinus floor. You can also see that there is associated inflammatory disease with polypoid mucosal thickening in the alveolar recess of the right maxillary sinus. As I mentioned, dental disease is the most common cause of referred otalgia, and the clinician should carefully inquire about the patient's dental history, conduct a careful inspection of the dentition, and they'll often gently percuss each tooth individually that can help elicit the pain and identify the involved tooth. On imaging, we may see dental caries with erosion of the crown of the tooth. the infection may spread through the pulp cavity and then extend through the apex, forming a periapical abscess, which is known as endodontal disease. And here on CT, you can see the typical findings of endodontal disease with dental caries. You can see complete erosion of the crown here and an associated periapical lucency reflecting the periapical abscess. We can also see periodontal disease, which is essentially gum disease. And the infection is around the tooth, beginning at the gum line and extending down the margin of the tooth, widening the periodontal ligament, which I've highlighted here in pink. On CT, you may see widening at the gum line, as in this case here, or you can see more extensive lucency surrounding the entire tooth, as you can see in this case on your right here. TMJ disease is the second most common cause of referred otalgia, and 70% of patients with TMJ disease will have otalgia, and otalgia may be the only manifestation. This most commonly presents in young women, and predisposing features include teeth grinding and clenching and previous mandibular trauma. Additional clues that this is the source of otalgia include pain over the joint, pain provoked by chewing or biting, and restricted jaw function. And here in this patient who had a history of right-sided facial pain, otalgia, and difficulty opening his mouth for 4 months, you can see anterior dislocation of the meniscus. The entire meniscus is anterior to the mandibular condyle, and it remains anterior to the condyle in the open mouth position. So these findings are consistent with meniscal dislocation without recapture, and it's the source of this patient's otalgia and facial pain. B3 also receives sensory innervation from the salivary glands, and so pathology of these structures can cause referred otalgia, and this is most commonly seen from the parotid glands. Here we have a patient with right-sided parotitis, and we can see hyperenhancement and enlargement of the right parotid gland with dilatation and inflammation of the parotid duct due to an obstructing stone in the distal duct. Pathology of the oral cavity can also cause otalgia. So this patient had a 4-year history of a right lateral tongue ulcer that was recently enlarging and also had right-sided otalgia. And here we can see that there is an enhancing FDG avid mass in the right floor of mouth that was a squamous cell carcinoma. So the facial nerve receives sensory innervation from the auricular region via the posterior auricular nerve. And the greater superficial petrosal nerve is also a branch of the facial nerve, which forms the Vidian nerve, and it enters the pterygopalatine fossa and receives sensory innervation from the nasal cavity and the posterior ethmoid and sphenoid sinuses. And so pathology of these structures that can cause otalgia include a nasal septal spur that contacts the turbinate or lateral nasal cavity wall, as well as sinusitis of the sphenoid and ethmoid sinuses. You can also have infections involving the facial nerve itself in Bell's palsy and Ramsay-Hunt syndrome, which can result in otalgia in addition to the facial nerve palsy. Ramsay-Hunt syndrome is due to reactivation of a latent varicella virus within the geniculate ganglion that can produce pain and facial paralysis. Patients also classically have a vesicular rash in the ear and external auditory canal. The vesicular rash, however, doesn't have to be present for this diagnosis. The rash can occur after the facial paralysis, and there's also a post-herpetic form of the neuralgia where patients have pain after the vesicles have resolved. The infection may also involve the inner ear, and patients may develop hearing loss and vertigo. On imaging, you may see abnormal enhancement of the facial nerve as well as of the inner ear structures, as we see in this case here. We can also see abnormal enhancement in the internal auditory canal. The glossopharyngeal nerve innervates the middle ear and tympanic membrane via Jacobson's nerve, and it also innervates the pharynx, the base of tongue, tonsillar fossa, and the parapharyngeal and retropharyngeal spaces. And so carcinomas and infections of the pharyngeal structures and the parapharyngeal and retropharyngeal spaces can all result in otalgia. And Eagle syndrome can cause otalgia through irritation of the tonsillar fossa. Otalgia can be the presenting symptom of a nasopharyngeal carcinoma, though it's fairly uncommon. Most commonly, patients present with a neck mass from metastatic adenopathy and conductive hearing loss from eustachian tube obstruction. But in a patient with otalgia, you want to look closely at this area for any asymmetric enhancing soft tissue. And here on this MR, you can see a small enhancing mass in the nasopharynx, filling and expanding the left fossa of Rosenmuller with a metastatic left retropharyngeal node. Here we have a patient who had chronic right ear pain, which was treated by the primary care physician with 2 rounds of antibiotics, thinking that this was due to ear disease. The patient was then later evaluated by an ENT surgeon who noticed a base of tongue lesion, and at that time was able to elicit a further history of weight loss for 6 months and voice changes for a month. And here on this MR image, we can see an enhancing mass in the right base of tongue, which was a squamous cell carcinoma. Tonsillitis and peritonsillar abscess can also result in otalgia, and these patients will typically also have fever, sore throat, and odynophagia. And here you can see enlargement of the palatine tonsils with this classic tiger stripe appearance reflecting tonsillitis. And in this different patient here on your right, we can see a fluid collection deep to the right palatine tonsil consistent with a peritonsillar abscess. Eagle syndrome is elongation or calcification of the stylohyoid ligament, and it can cause otalgia through irritation of the tonsillar fossa. Patients may also have cervical and facial pain and dysphagia precipitated by talking or swallowing. Now, only a small percentage of these calcified ligaments are actually symptomatic, and treatment includes NSAIDs, steroid injection, and resection of the calcified ligament. Pathology of the parapharyngeal and retropharyngeal spaces can also result in otalgia, and here we have a 52-year-old female with sore throat, fever, and right neck and ear pain for 4 days, and we can see a peripherally enhancing fluid collection located in the right retropharyngeal space, laterally in the right retropharyngeal space, just medial to the right internal carotid artery, not crossing the midline. And so this is consistent with a suppurative retropharyngeal node. The last cranial nerve to innervate the ear is the vagus nerve. The vagus nerve innervates the external auditory canal through Arnold's nerve, and it also receives sensory innervation from the larynx, the lower tracheobronchial tree and lungs, the lower pharynx and esophagus, as well as the thyroid gland. And so again, neoplasms and infections of all of these structures can all cause referred otalgia, even lung and thyroid cancer. So neoplasms are really one of the most worrisome causes of otalgia that we and the clinician do not want to miss. And these neoplasms can really arise anywhere along the aerodigestive tract. So carcinomas of the larynx, the hypopharynx, and the esophagus, as we see here. And earlier we saw carcinomas of the oral cavity, the oropharynx, and nasopharynx. All of these neoplasms in these sites can cause otalgia. And the clinician's suspicion should increase if the patient has a history of heavy smoking and alcohol use, or if they have risk factors for HPV. And they may have other findings, the patients may have other findings such as weight loss, neck mass, hoarseness, or dysphagia that may be helpful clues. But really the scary thing about these head and neck neoplasms is that otalgia may be the only presenting complaint, more often than many other causes of referred otalgia. And so in these cases, you want to look very carefully for any subtle asymmetry in the aerodigestive tract. There have been case reports of lung cancer presenting with otalgia, though this is quite rare. You want to review the upper chest, including the lung apices and trachea, included in all of your neck CT exams. And some authors recommend chest imaging in any patient with a long history of smoking and otalgia. Thyroid neoplasms and thyroiditis are also rare causes of referred otalgia, but something to keep in mind when evaluating these patients. Here on the image on your left, you can see a heterogeneously enhancing mass reflecting an anaplastic thyroid carcinoma. And on the image on your right, you can see hypoenhancement diffusely of the thyroid gland that was due to thyroiditis from immunotherapy. Finally, the cervical nerves C2 and C3 also innervate the ear through the greater auricular and lesser occipital nerves, which also innervate the cervical spine. So cervical spine pathology, most commonly cervical spondylosis, can also cause otalgia. And these are usually older patients with concurrent neck pain that can help suggest this as the source of pain. So if a patient with otalgia has a negative ear and otoscopic exam, then the clinician should be thinking about referred otalgia, and they should get a thorough history to determine the potential cause of the otalgia. Again, a heavy smoking and alcohol history or risk factors for HPV should increase the suspicion for a head and neck cancer, and pain elsewhere or other symptoms can, of course, help localize a source. The clinical exam should include evaluation of all of those structures innervated by the 6 nerves innervating the ear. And if a cause is found, then no further workup may be necessary. However, if no clear etiology is found clinically, then cross-sectional imaging should be performed to identify a potential source of the otalgia. So what does this mean for us with imaging? As with any head and neck case, you want to know the clinical history and clinical exam and whether or not an endoscopic exam has already been done. You want to look closely at all of those structures in the head and neck that can potentially cause otalgia, including the sinonasal cavity, oral cavity, pharynx, larynx, tracheobronchial tree, parotid and thyroid glands, and the cervical spine. Now, these are all structures that you likely already routinely evaluate in all of your neck CT exams, but understanding this extensive list of causes of referred otalgia will hopefully help you avoid missing subtle lesions and also help you communicate to the clinician some potential sources of the patient's ear pain. Keep in mind that while dental disease is the most common cause of referred otalgia, it is also a very common incidental finding. And so in patients without a clear clinical source of ear pain, you want to avoid satisfaction of search and consider alternate causes for the patient's otalgia. And again, the diagnosis that you don't want to miss is a neoplasm where otalgia may be the only presenting complaint. So in conclusion, primary otalgia is pain from ear disease, most commonly seen in children and most commonly secondary to acute infections. Chronic causes include cholesteatoma as well as neoplasms. Referred otalgia or secondary otalgia is ear pain from a source distant from the ear. This is more commonly seen in adults, with dental disease being the most common cause, followed by TMJ disease. And it can also be due to pathology of all of those structures innervated by the 4 cranial nerves and the 2 cervical nerves innervating the ear. Thank you for your time and attention.